Hello and welcome to IDF Europe Symposium here at EASD. It's great to see you all. I hope everybody has settled technical difficulties and is able to join us this first day of EASD. The World Health Assembly, as you know, has designated 2020 the International Year of the Nurse and of the Midwife. And the International Diabetes Federation has taken up this call. And that is why today at our IDF Europe Symposium here at EASD, we will talk about the future of diabetes nursing in Europe. My name is Bastian Haug. I'm a member of the board of the IDF Europe, and I have lived with diabetes myself for more than 20 years. And it is my great honor to now to chair this meeting and now welcome Niti Paul, the president of IDF Europe, for the official welcome and her opening remarks. Niti, over to you.
Thank you, Bastian. Welcome, everybody, to this very virtual seminar for EASD. Usually we meet in person. We see all of you. We have chats, but the world has taken us to a different place. So I do warmly welcome you to our meeting. As Bastian said, this is the year of the nurse and the midwife. And it's our very great honor to actually host this as our topic of discussion today. We as a family have also lived with diabetes, type 1 diabetes, for about 27 years now. My son was 3 years old when he was diagnosed. And the person that helped us the most was our diabetes specialist nurse. I will never forget her name. Her name was Adele. And Adele remains for us a member of our family, remains somebody that we could rely on when our son was 3 years old. She allowed Javier to remain at home. She allowed us as a family to adjust. He didn't need a hospital admission as a result. We had help when he went to school, when he moved schools. So the diabetes specialist nurse plays a very important part in the multidisciplinary team approach to diabetes care. For us, it remains a very big honor that we are able to host this seminar today and to have my very dear friend and colleague, Anne Felton, give the keynote. She is the president of FEND. This is the Federation of European Nurses and Diabetes. She's been a good friend of IDF Europe for years. She's also championed the cause of the nurse, not just in the UK, but all across Europe. We do know that the role of the nurse is always not the same. It's not standardized across Europe. And that's what we will attempt to do. And we will have a call to action at the end of this seminar. So I welcome you again. And it's my very great honor to hand back to you, Bastian. Thank you very much.
Opening remarks. It is a virtual world that comes with a lot of technical issues sometimes, and the challenge of keeping short and to the point in order to allow time for questions. And for all participants joining us from near and far, you can ask questions in the Q&A session, and we or I will try to get to most of them. Please understand that we might not be able to loop them all in, but we will get to your questions after the keynote. Anne-Marie Felton, it is my great honor to have you here. There is almost no need to introduce you. You are the president of the Foundation of European Nurses and Diabetes. And of course, your keynote will be on the role of the diabetes nurse across Europe today and tomorrow. Thank you for being here, and I want to hand right to you. Anne-Marie Felton.
Bastian, thank you so much for your introductory remarks, and also to Niti, because in fact I think Niti has actually given my presentation. So Bastian, you will be relieved. Perhaps I have nothing else to say. But such remarks aside, I do recognize that it is important to look to the future, but in looking to the future, we build from the past. Can I have the next slide, please? Okay, if you think of diabetes in Europe today, what makes you use your sleep? I've sort of modified Heinrich Heine's question, which he asked about Europe in the 19th century. Next slide, please. This is the reason. The reason are the numbers, and every number is an individual. And we know that this epidemic or pandemic is challenging all healthcare systems. And furthermore, with the advent of COVID, that has totally distorted healthcare systems because of the challenge of that itself. And that places at risk other chronic conditions which are equally deserving and essential that we continue our interventions and our partnership with people with diabetes. So we must, as a group of advocates, ensure that this distortion is no longer maintained. Next slide, please. Now, FEND has a mission statement like so many others, and I'm not going to read it to you. We will leave it there and I move on. I particularly want us to look at some elements of this slide which actually indicates the components that make up the role of the diabetes specialist nurse. And as your president has already said, not all of those are necessarily operationalized in every country in Europe. They're at different levels. But essentially, in establishing such a role, I believe it is not just I, but FEND believes that these components are essential. Some will develop even further and some may well drift away, but these are the key elements. It has been, to some extent, particularly in Southern or Eastern Europe, where the emphasis has been on the role of the educator, and that's hugely important. But the other components that allow educators to be competent is to ensure that they are competent clinicians. You need to understand the nature of the condition and the interventions that will actually enable people with diabetes to better manage their self-condition. And I also think it's important to be sensitive to the individuality of the person, because not everybody will always be able to self-manage. So there is, in effect, a lifelong partnership, but not a dominant partnership, triggered by the needs of the individual with diabetes. There is also another component in relation to research, and this is becoming much more manifest as particularly the academic research nurses in diabetes are much more competent in relation to research. So they are not just researching in the psychosocial elements or educational needs, but also in the clinical elements of research. And they are becoming not just collaborators, but PIs, and this is to be encouraged even more. Influence is important, and the relationship between the nurse as a specialist and the individual person with diabetes, be he or she a child or whatever, is absolutely is precious. And again, your president has so well described that relationship as it affected her own family and the lifelong journey for the individual with diabetes. And when the providers of diabetes services are addressing these elements, they need to take this into account, and not just lip service, but actually it is an active policy within the delivery of care systems. In terms of influences, again, that influence will be personal in relation to the individual with diabetes, the family, but at a broader element, locally, nationally, and internationally. And I did a rather quick scan of the interventions, so to speak, that have taken place, the key interventions at an advocacy level since the time of the St. Vincent Declaration. And I have reckoned, and it's not absolutely precise, there are about 16 active political interventions that have taken place in that time, more often driven by organizations such as IDF Global, IDF Europe in particular in relation to Europe, and of course the UN resolution on diabetes. These were very important interventions, getting governments to commit, but I think we need to really scrutinize the effect of those. There are some obvious positive effects, but they may be on the wane because of the competition of other diseases. So again, a wake-up call for all of us. I think the other aspect I know where FEND has made a major contribution, and I will just remind you that we are a voluntary organization. We have no staff, and we have no offices. So we really are virtual. So the work that is done is because of the support we get from key organizations from the pharmaceutical industry, and we are grateful to them, because without their constancy, this would not happen. So we have an MSc program, a 3-year program, which is academically accredited at King's College, University of London, and led by Professor Angus Forbes. Leading from that, we have an PhD program, and leading from that, a postdoc program. And these are fully funded by FEND and available to all of our members who meet the criteria in terms of university admission. So really, I want to spread this message, particularly to Southern and Eastern Europe, so that nurses working in the specialty of diabetes can actually access these programs, provided they are members and meet the academic criteria. They are free, and I assure you that all of the nurses who have already undertaken this find the international nature of the program, the networking, just so very valuable. So where do we go from here? Well, we will know, you and I and all of you listening. Somebody needs to mute their speaker, because I'm getting an echo. The national diabetes registries are really very few, and really probably the most reliable one is in Sweden. But we need reliable data in order to monitor how effective we are, but also to make sure that the programs that are being delivered are relevant to the people with diabetes. And particularly as we probably move now in the not too distant future to precision medicine, which is different from personalized care, then this will be absolutely critical. And it will require a different way of delivering care. I don't know what that will be, but you can actually, I'm sure, influence that. I'm getting a little bit too old to look 20 years ahead now in relation to that. The other aspect I think that must be much more attended to is the concept of PROMs. This is meaningful metrics to include patient-reported outcome measures. This is truly an important part of the research element. And I would also suggest that in certain areas of research, that people with diabetes must be included in the research agenda, i.e., I mean, in developing the policies that are relevant to them with the basic and clinical scientists as well. This, I think, will manifest what we mean when we say person-centered care, person-centered research. We also are committed to the concept of interdisciplinary academic shared programs. And again, this must be properly academically accredited through the universities or relevant institutions. These are not just one-day courses. So, and this is to be sure that we as people, professionals, are relevant and competent to people with diabetes. Therapeutic patient education is critical for people with diabetes, and in that agenda, we must share with them, I hope, and they will share with us their needs and how they wish to see therapeutic patient education integrated into the whole system of management, but always person-centered. For tomorrow, leadership is critical. And IDF Europe, as the central organization in Europe representing the organizations of people with diabetes, should lead on this. Leadership programs. Leadership is not acquired. We're not all born with leadership skills, but we can acquire them. And I think this is an area that should not be left on an ad hoc basis. I have mentioned the importance of academic collaboration, and we in FEND will continue our MSc programs, our PhD programs, and our postdoc programs, but they too will change in the light of need and in the light of the monitoring that we do, which will indicate that. Political advocacy is absolutely important. And I mentioned already the various interventions that have taken place at a European level and at a global level in terms of advocacy. It can create significant awareness. But it is extraordinary how awareness can drop from the political level so quickly. So we must be alert to that. So political advocacy must be part of the continuum of the policies in relation to diabetes at a national and international level. And then sustainability, the partnership with pharma industry, the partnership with the diagnostic industries. This notion that, pharma or other industries might be corrupting, we must make sure that that's not the case. But they are as much part of the solution as we are. And if we exclude the pharma industries relevant to diabetes, then we are not serving people. And I wish to state that absolutely publicly. Engagement is critical. Okay? And Sebastian, I'm not quite sure whether I've hit the 7 minutes or not, but I've never been so breathless in my life. I will finish with a quote from Florence Nightingale, who is the founder of modern nursing. And also it is our 25th anniversary of the foundation of European Nurses and Diabetes. For us who nurse, our nursing is a thing which, unless we are making progress every year, month and week, take my word, we are going backwards. FEND is not going backwards, and with you, we will really go forward as true partners. Thank you so much.
Anne-Marie Felton, thank you very, very much for these keynote words. And yes, you were a bit longer than the 7 minutes we agreed, but still within the time frame. So thank you for being so brief and to the point. Thank you also for your kind words towards IDF Europe and your remarks about leadership. And I would already like to point out the last speaker today, Martje, is a young student nurse who was part of the youth program of IDF Global. She went through that young leadership development program. She now works at IDF Europe. She is going to study, going to become a nurse, and we will have her as our last speaker today. As for your other point, the main thing that I take from your presentation for me personally, and I think this will resonate with many people with diabetes out there, is that every person with diabetes should have a designated diabetes specialist nurse at his or her side. And I can only echo this from my perspective as someone living with diabetes. While I only have maybe 15 minutes every 3 months with my HCP, with my endocrinologist, my diabetes nurse has a lot more time for me. She's available to call her up, sometimes even in the middle of the night, which is probably not standard, and these days even via Zoom calls like this. Anne-Marie Felton, thank you very much. We will not take any questions to you specifically at this point, but you have agreed to stay on throughout the next 45 minutes or so, so we might come back to you throughout the panel discussions.
Good.
And feedback. Thank you very much. With that, I would like to head over to the panel discussions, because as IDF Europe, we have decided what better way to talk about the future of diabetes nursing than to do this through very short statements by different people, through different perspectives, and not have long presentations to bore you with. So we will go straight to the first panel, and please do submit questions in the chat function of the EASD platform so that our panelists can respond to them later on. Our first panel will be on the shifting tasks to explore new ways of providing diabetes care, and of course, looking into the place of the diabetes nurse today and tomorrow. And I will introduce speakers one by one as they come up. I would first like to introduce Miklos Soska. And Miklos, I apologize already because I know I'm not pronouncing your last name right, although you have tried to explain it to me.
Don't worry.
I will stick to first names. Miklos, you have been Minister of State for Health of the Hungarian government for a number of years, and you are now the director of the Health Services Management Training Center that actually you created yourself all the way back in 1995, and you're back as the director of that, and you're also the Dean of the Faculty of Health and Public Administration at Semmelweis University. You will be presenting the policymaker's perspective, but with your different hats on. I know you can kind of seamlessly move between different views, but focus on that. We look forward to hearing your introductory remarks.
Thank you very much, Bastian, and I tried to do it in 3 minutes. You know, when I got this invitation, you know, I had a lot of thoughts about the issue, and you know, if I just want to explain you the word cloud that is in my mind, is one is optimism and the other is concern. These are the two largest words in my word cloud. First of all, I'm an honorary nurse. I became an honorary nurse during my term in office as Minister of State for Health. So this is a huge dignity because it is the nurses who invited. But I think this was based on the personal experience because I grew up as a son of two tuberculosis doctors, and my mother was the coordinator and liaison person to the Green Cross tuberculosis nurses. And I grew up them sitting around the kitchen table talking to my mother. So the team was there. So it was so natural that there are things that the nurses can do and there are things that the doctors do, and they coordinate. So this was the natural approach in my entire life. And, here at our school, doctors and nurses are studying at the same management program. So that there has to be, and whenever we initiate a change project, it is always a 3-person, a doctor, a nurse, and a financial person. So that's they have to bring all their special knowledge. And when I'm thinking about digitization of diabetes care, then there comes the concern. Because the nurses are committed, so I'm optimistic. The nurses are committed. They are ready to take up management job. If nobody organizes, they are willing to organize, and they have the practical approach to do it. And they are picking up more and more responsibilities, where they represent a very limited resource at the same time. So this is I'm optimistic they can do it, and they will do it, and they will lead it. But they are picking up more and more responsibilities, more and more high-skilled work, because their training is developing along the centuries. So they're really able to do more, while the traditional nursing work is still on their shoulders. So it is, and the number of chronic patients is just flowing in. So who does the job then? If they are ready to take more on one front, who replaces them on the other front? And there are also demographic problems, just like with doctors, the nurses also experiencing scarcity of resources and demographic issues along the way. So my understanding is that the huge challenge here is that they will be able to adopt their work to digital. They will be able to solve this integrated patient pathway support. So they will be able to do it, and they will be able to organize it, and they will be able to provide the service and keep together the process. But we will have to, and they will be able to switch from manual to digital, but they also have to do this link between digital, between technology and the human. And my biggest concern, will we be able to support them with training programs? Will we be able to support them with recruitment? But my other optimism is that whenever the nurses are authorized, they are capable of organizing the work differently. So my understanding is that if there are scarce resources, I hope that they will be able to organize the scarce resources better, because digital has this promise that even if we have scarce resources, we still will be able to reach more people. The question is support, the question is incentives, whether we will be able to do them with training programs, organization of work, technology, training in technology. That's the challenge that we have to solve, to let them work and let them do the human side of the care, even in digital formats.
Miklos, thank you very much.
Thank you very much.
I would have a personal first question to you, but I will leave that to later. But that will be about what do we have to do on the policy level? You as a policymaker, a former senior policymaker, what will we have to do on the political level to make this vision of yours, of Anne-Marie Felten as well, become a reality? But before we go there, it is my honor to now welcome Kirsty Winkley-Bryan, sorry. She is, while you are an honorary nurse, Miklos, she is a real diabetes nurse. She's also a health psychologist based at King's College in London. And her expertise is on supporting people with type 2 diabetes, with structured education and with psychological interventions that support self-management that is so important for living with diabetes, as we all know. Kirsty, from your perspective, how do you echo what you heard from Miklos and from Anne-Marie Felten?
Well, I'd like to thank both of them, and you, Bastian, and Niti as well, for your comments today, and especially to Anne-Marie for her presentation on the future of diabetes nurses in Europe and beyond. I completely agree that, diabetes nurses, we are there really, our focus is to support people with diabetes to self-manage their condition. And because of this, it therefore has its own clinical and therefore research remit. And as a group of nurses already, we are already specialised in paediatrics, type 1 diabetes, type 2 diabetes, also in community and primary care nursing. We have specialists in delivering structured education for diabetes, but I feel that these roles can be further expanded, all based around self-management. So, for example, we know that not every nurse or not every diabetes nurse can become an expert in the psychological techniques required to counsel somebody with diabetes. However, some will have those skills. Also, some will be experts with digital technologies, pumps and the like. And whereas we need more work around supporting people within the community, so people with, the aging population. For example, what happens to people with type 1 diabetes who are on multiple injections, living out in the community when they're very elderly? Perhaps now they'll have insulin pumps in the community. How do we manage that? I think we also need more outreach work into disadvantaged and ethnically diverse populations in our communities. We might be moving away from sort of secondary care more into primary care to delivering care locally for more people. And finally, and I think this is where FEND and Anne-Marie has made such a massive introduction and has helped lots of diabetes nurses become academics. We do need to promote the clinical academic posts for diabetes nurses. Anne-Marie's explained about the MSc program that FEND offers, and she's also talked about the PhD and the postdoctoral programs for diabetes nurses. But what we also need is we need more clinical academic posts for diabetes nurses. Because these are, as we say in England, as rare as hen's teeth at the moment. But this is the best way we can develop the support we can give to people with diabetes by keeping our nurses, our diabetes nurses, active clinically and academically and conducting the research that is required. Yes, we will need leadership programs, as Anne-Marie has explained, and we need to be able to influence every level of the political agenda to do this as well. So that's what I'd like to say. Thank you very much.
Kirsty, thank you very much. And I see Anne-Marie Felton nodding. I think you too would be very much in agreement on most of these points. So this is where I would like to come back to Miklos. If you could turn your camera back on, please. I would really like to know from you, Miklos, if you're hearing if we are hearing now what Kirsty, what Anne-Marie Felton are calling for, what they think would be important to increase the role of the nurse in society across Europe, what would be for advocates like them, for nurses with their feet on the ground, what would be the best 3 things maybe to do to address policymakers like your now former colleagues to make that a reality? What are the best levers to push or the best buttons to push to get this done?
This digital transformation in-house is a very complex exercise because it is, as Kirsty said, this is coming from specialist care to primary care. So it is not just the specialist care regulations and minimal conditions changing, but its primary care conditions are changing. And it is not necessarily personal meetings, but support through digital means. So personalizing through digital channels. So it is a huge regulatory issue. But on the other hand, my understanding is that politicians are a very strange form of life. If you provide them oxygen, or if you provide them nitrogen or whatever, they try to make votes out of it. And they are very good in talking in infographics. So whenever is an election campaign, they just infographicing their opponents and they're translating everything to 20-second messages or 10-second messages or an SMS or tweet messages. So the number one is that we have to, and there's a lot of trouble between health policy researchers always complain that, oh, those politicians do not understand evidence. Yes, they do not have patience to understand it, and you have to provide them in a way that they can turn into votes, nitrogen to votes. So you have to try to package it. They have to try to package it into political communication products. You have to show them how easy to create value for society through reorganizing nursing work in diabetes care. Sorry to say, but we have to be able to translate it into political communication products. And it is not selling out the very important issues, but we have to grow up to the task and understand that they are thinking in infographics and they want to turn everything into votes. So we just prepare them these packages. And you have to talk to the fiscal decision maker and the political decision maker, not just the health. The health ones understand it, but on top of everything, the fiscal decision makers are risk averse. They do not necessarily understand the nature of long-term investment. So they are not investment bankers, they are accountants. So you have to be able to translate this thing to the risk-averse fiscal and the political communication, political decision makers. So we need a translator engine.
And Miklos, I know that this is something that you specialize in. You once showed us at IDF Europe and also in another group we've been working together how you personally started employing designers, visual graphic designers, to make your own agendas more likely to become a reality, and it worked. And I think this is great advice for people like Anne-Marie Felton at FEND, also for us at IDF Europe, to put ourselves in the shoes of policymakers that we lobby towards, that we want to address, that we direct our advocacy towards, to also make sure that we're not only talking about content, but also talking about it in a way that is apprehended and understood by those that we want to help us change reality on the ground, be it through visuals, be it through helping them transform, as you said, oxygen into votes. I don't know, Anne, if you want to react to that. Is that something you can respond to? Does it feel like that's something you could do to make your calls to action more likely to be apprehended?
Okay, thank you. And thank you very much, Miloš, for your presentation. In terms of moving into this other world of virtual communication, I think in many respects, nurses have been doing this for a long time, either through SMSs or emails or phone calls, you name it. And but, of course, it's not structured and it's not actually accounted for in the planning. Now we're moving into a different era. But I have a word of caution, and I think it's beginning to bubble up. There was much relief after COVID when we were, again, able to engage with people with diabetes in a virtual sense, because at one point it almost seemed we were going to lose total contact because of the disruption in service provision. However, we really need to take into account that there are times when it is actually important to be in the physical presence of each other. So let's not throw out the baby with bathwater. And that applies both in primary care, in community care, and secondary care. And in some respects, I would prefer, as others would, I'm sure, to have this whole thing working together and not take down these barriers that may exist currently in our healthcare systems, and we may inadvertently ourselves be promoting it. So it does require a rethink. Now, in terms of technology, Bastian, you will know that I am a disaster when it comes to technology. I can hardly use a telephone. That's why I'm so grateful to my beloved husband to be so patient with me with all of this. But if any of you have listened to the President of the EU Commission on Wednesday last in her State of the Union address, now she addressed many areas relating to policies and politics in the EU, but she concentrated particularly on health, not least because of the implications of COVID. And they are establishing, listen to this, go back to her presentation, a major conference on health in Italy next year. Now, Italy was the bed of the St. Vincent Declaration. All of us as a group need to come together, and I have already written to this woman to say, we're here, you know, what arrogance, it's not meant to be arrogant. I do want to remind these people that it is the non-governmental organizations that are the drivers of health and indeed the major funders of research. And research is under a real threat because of COVID, because it's going elsewhere. So, IDF Europe, Primary Care Diabetes Europe, FEND, let us come together as a group and make sure that we are present at that meeting, not only present, but actually shaping the agenda. Thank you.
Thank you, Anne. In the interest of time, I would like to move to the next panel, but I would like both of you, or all three of you, sorry, Kirsty, Anne, and Miklos, to stay on, because I would like to bring you back in. But as we're now already talking so much about digitalization and the role of the nurse and how important it is on the one hand, but also how difficult it can be for some, I would like to turn to our next three speakers and discuss that, because our next panel is in part about harnessing the digital transformation and how the nurse can facilitate it, but also what will be important. I would like to welcome three of my colleagues at IDF Europe, Aldona, Tatiana, and Martje. Aldona Dalien is a diabetes nurse. She is specialized in foot care and prevention. She was elected to the board of IDF 2019, so last year, and she's also the vice president of the Lithuanian Diabetes Association. So Aldona, I'd like you to start with a couple of words on the role of the nurse in Lithuania specifically, and if you could also touch upon digitalization, whether you as a nurse can bring that into clinical practice, that would be great. Aldona, your presentation, please.
Dear symposium organizers and participants, I have been working as a nurse for more than 40 years and have seen many important changes in recent years. The development of technologies has had a big impact on the lives of medical specialists as well as patients. The COVID-19 situation has highlighted some of the challenges of digital health for doctors and nurses. During the quarantine, most consultations were done via telephone, email, and Skype. It's a pity that majority of our patients are of older age and we are not willing to use online platforms such as Zoom, for example. Regarding the use of digital diabetes devices in Lithuania, patients up to 24 years with type 1 diabetes may rent the pumps from the government. This is reimbursed by the National Health Insurance Fund. This is not the case for all the people who have to buy them. About 20 years ago, diabetes doctors and nurses faced the problem of shortage of data. Nowadays, they face the opposite problems. They are overwhelmed with the data. I see a real need to train people to understand the information they get from digital devices. Diabetes nurses should also learn how to analyze and use the data that is collected. They should also be trained about the latest development in the field of diabetes to help support people living with diabetes. Having in mind this huge flow of information, one of the main goals for us is to educate specialist nurses. A seminar was held early this year for diabetes nurses to tell them which were reliable sources of information, to teach them how to search for evidence-based information and how to avoid using misleading information that is available in many non-official portals. Using new technologies will ensure better care, but continuous training is needed for diabetes nurses. This should be part of the discussion they need to engage in with policy makers. I pass my best regards to all who are involved in this interesting but not easy way of assimilating new technologies in this field. Thank you.
Thank you very much, Aldona. And I think you made it very clear once again, and I'm pretty sure that both Anne-Marie Felton and Kirsty will agree with what you're saying. And there's also a question from the audience towards this, or rather a side comment, that as great as technology in this digital world is, we have to make sure that we don't leave anyone behind. Because one of the comments from the audience right now is that there's someone saying that she's working in an integrated community team looking after people with type 2 diabetes, but many are elderly and don't have access to these kind of technologies. And that's why the role of these face-to-face meetings that you were also talking about and that Anne-Marie just put back into focus are so important. Tatiana, I would like to move to you and ask for your perspective as well. You're a professor of internal medicine at the University St. Cyril and Methodius in Skopje in Macedonia. And you're also the president of the Macedonian Diabetes Association and another fellow board member of IDF Europe.
Okay, dear Bastian and dear colleagues, thank you for a kind introduction. It is a real pleasure. I will be very short with some remarks that we can discuss further, of course. So when we are speaking about digital health technology, especially for different digital health apps and websites for people with or at risk for diabetes, all this digital technology has developed at a big and rapid step. And it became an increasingly common aspect of diabetes care and self-management in this population. So from a physician perspective, from my own, of course, first perspective, this is like for any other question or matter. There are a lot of positive, but also some negative aspects of this rapid digital transformation that we are all facing in every aspect of our life. So this virtual reality can help physicians to get better training. In the same time, a large amount of information can be collected, which can lower the rate of medical errors, which can facilitate the preventive care and help for better allocation of some medical staff for patients' treatment. Or to be actual, during these COVID-19 pandemics or at some distant places, the use of digital technology enabled telemedicine consultation, which can protect patients and healthcare providers as well of infection, and still they can be in a contact for the need of the patients. And maybe for me, one of the most important is fact that development of these different technologies can provide digital and objective data accessible to both healthcare providers and patients. And actually, this can lead to an equal level of doctor-patient relationship. This can go to a shared decision-making and a democratization of patient care. And of course, with this, with well-educated patient, we can put the patient at the center of care. But however, there are several barriers that remain that actually prevent this digital technology from reaching its full potential to improve diabetes treatments and lives of people affected by diabetes. So first, there is an insufficient evidence, so lack of evidence, at least from a conventional way of looking at evidence, how physicians look at evidence, of clinical validity, effectiveness, accuracy, and safety on these different apps and websites that patients are using for their treatment. Then, of course, we are facing every day the poor usability of this digital technology, which resulting from some technological issues, but also differences among population of healthcare providers and patients. And for me, it will be always a drawback, lack of personal contact. For me, it's very, very important way of communication with patients for better understanding, for empathy, and other support that patient may need during his or her healing process. So thank you for the moment.
Thank you, Tatiana. So much for the physician's perspective. And again, some words of caution there. And I think it is great that we started with both you and Aldona giving, a very optimistic approach towards digital data and digital transformation, but also always repeating this need for having the person first and having the person first in contact to the person with diabetes. And this is why I'm now especially happy to welcome Martje, who represents a curious mix, because she is representing another generation, of course. Martje, you're in your early 20s, you're studying to become a nurse, but you also live with diabetes, so you can both give the perspective of the person living with diabetes, but also that of a future nurse in training. Because all of our speakers, if I've listened correctly so far, all of our speakers so far have stressed the need for better training moving forward. They have also all addressed the need for digital transformation, but said we need the person at the center, be it the person with diabetes or also the nurse, to make sure there is a personal connection. Now, from your perspective, both as a person living with and as a future nurse, I'm really curious to hear your perspective on digital and on the role of the nurse in the next years to come, which will be yours.
Thank you so much, Bastian, for the opportunity. So although I am officially seen as someone from the Zoomer generation, well, I'm very critical when it comes to diabetes and technology, because personally, I will always choose to have a face-to-face meeting with my diabetes nurse instead of an online meeting, because this can never replace the very special bond or relationship that you have between a person with diabetes and a nurse. However, I think that digital innovation can be a great added value to the relationship and increase the contact with the patients in any way. But looking to the future, I'm personally scared that technology will take over from the actual warm and human contact that you have with your nurse or doctor. For example, when I was younger, I sometimes lied about my glucose levels because I was scared of not being good enough. Because of the fact that diabetes nurses have such an important role in my life, they gained my trust over the years, and opening up to them became something natural, like a natural habit, because of the unique bond that I have with them. But still, technology can play an important role, in my opinion, for people that have difficulties on that side about opening up and being honest about their lives. Because when you use an app such as My Sugar, where you can easily report on your stress level, your nightlife, your emotions, it's way more easier, especially, I guess, for a young person, to just press a button and send it to my diabetes team, rather than telling it face to face. So, which sometimes can be more confronting, and in some way with technology, there is less of a burden to do that. However, not all diabetes nurses are aware of those apps, and therefore I am not really able to share the data. So in the way that it's invented to make my life more easy or in that way. So digital health platforms should be more centralized, and in the different apps should be more encouraged to the patients and well known by nurses. Although they do their very best, because in some way they are aware, but it's still digitalization and sometimes it's difficult. From my perspective as a nursing student, well, in Belgium, you need to follow 4 years of general nursing education, and after that, a postgraduate to treat people with diabetes. But although diabetes is an important part of the curriculum, I feel that there is still a lack of education and knowledge about diabetes by nursing students. And for example, at my school, they put diabetes in an online course. So first you need to go through all the information about diabetes and treatments and a few parts of innovation. And then you need to do an assessment. So the flipped classroom part can be more fruitful in my eyes, and rather to just sit and listen. So it's good that they play more attention on that side. But even then, it's an NCD that needs to be highlighted more in my eyes as a patient, or I don't like to use the word patient, but as a person living with diabetes, I feel that it needs to be supported more. And when it comes to innovation, in my eyes, the diabetes nurse needs to be the number one person that is aware of innovation and technology and the devices and stuff. But when you talk to a general nurse, so without a specialization in diabetes, they acknowledge that they are sometimes scared of hospitalized people with diabetes because of they are not aware of insulin pumps, CGM, and in general, they are constantly scared of people with diabetes because they can have seizures and they can have severe hypos. So, and in that way, there needs to be, I feel that it's a side effect of a lack of education about diabetes. And I also feel when you centralize all the different diabetes platforms, this will be the ultimate key for multidisciplinary teams and to communicate, but most of it to stay in touch with their patients and increase the quality of life, because you have more tools to do that if you are going with the flow of innovation. So the future is online. It's what we are doing now also. But still, I think that nurses and doctors need to jump on the online train, but with the perfect balance between staying humans and the warm contact and not becoming robots, because everything would be online. So that's my perspective on innovation and technology.
Thank you, Martin. It's interesting coming from you, as I said, from a person living with diabetes, but also from a future nurse. And I would like to, if you're still there, Kirsty, I would like to loop you back in and ask you from your position how you respond to that. You are specializing mostly in treating or in supporting elderly people with type 2 diabetes. If you hear Martin now from the new generation of young person with type 1 diabetes and future nurse, how do you respond to that? How does what she would like to see more of and what she's being trained for to do in the future, how does it respond to the reality on the ground that you're confronted with in your day-to-day practice?
I think it's quite distressing in a way, Marcia, that even now student nurses and perhaps inpatient nurses are still not do not have the right level of expertise for people with diabetes, and it is a bit depressing, to be honest. And I know that within the nursing school at King's College London, the diabetes department, my colleagues, we're currently developing nurse training around diabetes, and we are redesigning the curriculum so that diabetes is threaded through the whole curriculum for the student nurses. And I think, unfortunately, when you do qualify as a nurse and you're working within a hospital environment, it is still the case that most general nurses do not have enough expertise of diabetes. And it's only really when a general nurse decides themselves to become more of an expert in diabetes or that there is a specialist team attached to the hospital who can facilitate additional training. And that's really what happened to me. Was I was interested. I wanted to find out more. I felt that I didn't feel confident managing insulin with people with diabetes, and I wanted to know more. And that's how my development into a diabetes nurse started. And the reason I was so interested was that the diabetes specialist nurses I met along the way were so inspirational. And I just felt that it was a specialty where I got so much back from the other health professionals, and both the doctors and the nurses, the whole team actually was just really, really strong at King's. In terms of the future, in terms of digital technologies, Marcia, you said that really nothing really takes away that relationship that you have with the nurse. If you're the person with diabetes, it's all about relationships. And that really applies to every relationship with a nurse and a person with any condition any chronic condition within the hospital environment, within primary care, secondary care, in the community. And I think part of the reason that most nurses go into the field is because they want to have that relationship with people, because it's certainly a two-way process, and we get so much out of that relationship. So I think we need to see the sort of the digital aspect as an opportunity that, you know, not everybody is going to become an expert in digital technology, and not every person with diabetes can access those technologies. And so we need to be really person-centered. And it's going to be like any opportunity that comes along within healthcare. It has to be well managed and well planned, and we need to be able to help people who are disadvantaged when it comes to technology, as well as those people who are more able. So yeah, I think that's what I'd like to say, and welcome Marcia to nursing.
Miklos, if you're still there, I would like to loop you back in. We've heard a lot about the need for a good balance between good training for diabetes nurses in the future, plus digitalization. And there has been, if I listen closely to all these different perspectives from nurses, future nurses, HCPs, but also from you said something of the same thing. We need both in the future. We need good nurses. We need time for people with diabetes to have that personal relationship to their healthcare team. This is what's behind the term integrated care as well. But we also do need digitalization in order to harness the power behind and make things more efficient and also more cost efficient. From a policymaker's perspective, to come back to your background, A, do you think we'll be able to pull this off and get that balance right? And B, is that a risk that some of these fears that we heard about, that digital might, take away from the focus of the personal and on the role of the nurse? Is that a real risk scenario that we're facing? And what would be, that would be the last question, what would we have to do in our communication around this to prevent it from going just down that road?
Yeah, thanks a lot. It is basically what is the mission of a top health policy maker? Number one is making the citizens healthier, or helping them to keep their health as long as they can. The second one is to have a sustainable, efficient, accessible, good quality service for those who get sick. And the third one is that those people who are in the system, keep them motivated and allow them to innovate. So this is these are the three messages. And the fourth one is to win the elections, but that's for the politicians. But so if you look at this, it is the patients. And sorry to use military terms. In the First World War, there came the airplanes and there came the tanks. So this is a new weapon, and they did not really know what to do with them. So they used the airplanes like those heat balloons, and they were throwing grenades, and they used it for reconnaissance. And in the Second World War already, there was a special, the Luftwaffe, for example, for the Germans. There was a wing of military with airplanes, and they have developed completely new tactics. And just like tanks, they were frightening. This is an English invention. They were frightening for the Germans, and when the Germans innovated it, then it was frightening for the Brits or the Allied forces. So no, but they did not know what to do it. And in the Second World War, there was a blitz, and the others had to adopt to that. So this is so what I mean is there's a new tool in our weaponry against disease. Will it be assigned to each troops, or will there be a special digital troop? There will be a digital national health service, and I agree with Marcia. There should not be too much variety of technologies, because then the equity suffers. So the health strategist, they have to think it over. How do we use these new weapons or these new tools against the disease? How should we organize care? How should the troops, the land troops against diabetes, how should they use the technology? And then we have to train them, because we have to learn how to how to drive a tank. And we have to talk to the designers. Will it be ergonomic to drive that tank? How we will ensure ergonomy for the gamer generation, and how do we ensure ergonomy for the old multimorbid chronic patients? Because the ergonomy means completely different for these people. So now this is really a disruptive age, and those who can live with the technology can keep the human-digital balance and can translate the humanity, even on digital terms, because, I agree, humans are in the center, and we are doing this, we are doing it personally and digitally, we are doing to heal patients, heal or support or assist people living with chronic conditions. So that's what we are doing. So now we have to reinvent the new paradigm of war on disease. Sorry to use this analogy, but yes, we are, and we should not forget that the digital means could help us in prevention, because the digital marketing is advertising habits that are harmful for our health. But how can we use digital technologies for prevention, not just to treat the consequences? So that's the way I see it. And for that, we need training, we need technology, we need discussion between the designers and the nurses, with patients involved. So this should be a co-design of the care and the technologies.
Thank you, Miklos. I'm not quite sure I like the analogy of using terminology of war weapon, but I definitely agree that it's a whole new generation of tools we're currently seeing, and they can be very powerful, and they can be used by existing nurses or by a new branch of specialists in healthcare to work with people with diabetes.
Sorry for this war analogy, but it is so easy to digest. And precision. We were talking about precision medicine, and now there is this precision bombs. Sorry about it, but there is some analogy.
We get it. And for that, Miklos, last call, for that we will also need funding, and funding starts with raising awareness that this disease is a pandemic that is affecting all of Europe, that is affecting millions of people throughout our continent. And go ahead.
And sorry, that's when the EU could come in, because every country, health is a national issue. But if we go through the legislation and the funding sources of private or public health insurance, that's too long. So EU should invest development funds in large experiments, large pilots, just to let the policymakers gain experience with the new ways, and then institutionalize it. So that's where the EU has a lot of, and the NGOs, the EU and the partnering NGOs have a lot of role.
Thank you, Miklos. Martje, last call for you. Are you happy with using digital as a weapon or as a tool in your arsenal?
Well, I'm very happy that I have technology. It's difficult to use the word war, but in a way, I think if we use it properly, it can be something very, very helpful. But also regarding burnout and other things, technology is also, I always feel that it's also a dangerous thing sometimes. So it's always finding a right balance, not for doctors and nurses only, but also for the patients or for the person living with diabetes, of course. Yes. So a difficult way to go, I guess.
Thank you, Martje. Anne-Marie Felton, president of FEND, has asked for a last chance to comment on this, and then we will head over to Nebosa for the closing words. Anne.
Thank you so much for indulging that request. I have listened very carefully to the panelists, the two panelists. It really is most interesting to hear this. I have a particular comment to make. I know that this symposium is addressing the role of the diabetes nurse today and tomorrow, but it is an interdisciplinary team. And each of those comments that have been made, particularly in relation to training and using digitalization technologies, this is important for all of us. And yes, nurses are taking on, and understandably, particularly the specialist nurses, more elements of delivery of care. But it is not to absent the other specialists. They are equally important. The diabetologists, the physicians, the primary care physician, the dietitians, the psychologists. This is a game for all of us. let's not enter into another silo era. It's not appropriate. So, yes, I think that there is a real call for all of us to come together in a structured way, maybe pre this meeting that the Commission, the President of the Commission of EU is planning, so that we get our ducks in order, so to speak. I do come in peace. I do say that, and I know metaphors have been used in other ways, but they are important. And if I can come back to Marcia, because I met Marcia in IDF Europe. I happened to be going to a meeting, and quite by accident I popped in to say hello to Elizabeth, and there I found Marcia. Now, what I want to say about finding Marcia is not so much Marcia, and just forgive me for a moment, is the initiative that IDF Europe has taken in making it available as a visiting experience for others. And I would like to see, and this is a special request to the board of IDF Europe, how we in FEND could work with you so that we could provide fellowships. We do already in other areas, or award them in such a way that somebody could spend a month with IDF Europe, a nurse from Europe, to see how you operate at this regional level. I think we can become more effective. I'm not asking you to fund it. We'll find the money somewhere, we always do, but it would be so precious, so precious. And I'd love to do it myself, but, you know, I'm not practicing. But this would be an important initiative. And I want to reiterate, although we are calling, this is FEND globally, on World Diabetes Day, that every person with diabetes should have a named diabetes specialist nurse. Thank you for your support of that. Obviously, that will have to be fleshed out more, but it's probably a 5-year campaign. But without you, we can't do it, because it is your organization that represents people with diabetes. And my final plea is that every national organization, particularly in relation to research, should ensure that there are at least 2 people with diabetes on the research board. Thank you all. It's been so inspiring. Thank you so much.
And thank you very much again for these very kind words. And your call has been heard by at least 5 people here from IDF Europe. And I can tell you in not so private right now, so I won't go into details, that we are actually discussing something like this right now, something like what you have been calling for, more exchange between our member associations and our offices in Brussels to encourage people to go back and forth and learn. And this will, of course, be open to nurses as well. So you might hear more on that in the future. Thank you very much.
Thank you.
In the interest of time, because we've also already gone over time quite a bit, I would like to thank all speakers present today. Niti for her opening words, the president of IDF Europe, and of course for her great keynote speech and coming back in with comments. Then Miklos and Kirsty for the first panel discussion and for allowing me to immediately merge into the second panel with Tatiana, Aldona and Marcia. And I would now like to hand over to Niti. I just see you're putting your video back on. Maybe I will hand over to you and then to Nibosa, our president and our vice president, for closing remarks to both of you.
Bastian, I was just showing my face again, just to say I'm still here. But thank you very much for chairing it. I'd like to just thank Bastian for so ably chairing this meeting. Thank you very much. I'll hand over to Nibosa.
Thank you. Thank you, Niti. Thank you, Bastian. I might, doing my task, I have 2 pitfalls. The first one is that I'm standing between you and the lunch, which is very, very dangerous. And the second one is I'm in a danger to repeat the things that you already said. But like take-home message, I think, and all of us thought that it would be nice to have a sort of take-home messages or some basis for a call for action in this area. So I'll try to be brief, and I'll try to emphasize some rather important and most important things that have been mentioned. Evidently, we are all acknowledging that modern diabetes management is progressing in a way that it is based on diabetes team, and within that diabetes team, it is diabetes nurse that has a very, very important role. On the other hand, when diabetes nurse is engaged into this team, diabetes nurse, it needs to be educated in a way, on one side, educated in a way to put up with the constant development of diabetes care technologies. But however, there is also a need that it should be trained to individualize this type of treatment and to adapt all that to the particular needs of the patient. And I liked very much, I think it comes from Anne, this sentence that every person with diabetes should have a named diabetes nurse. So this is the goal that should be attained. This is the goal that should be, I think, made real, at least realistic in more and more countries in Europe, and it is something that we should try to do Europe-wide. In this context, however, we need more. We need that formal education system recognizes it, and that finally, in many countries, except apart from the education of general nurses, we have established a formal education system for diabetes nurse, and regarding healthcare system, that we should define an adequate positions at all levels of care, because diabetes nurses are needed at all levels of care. In some countries, there are, as we heard, diabetes specialist nurse, but let's start from something that would, let's say, try to be homogenize the approach in all the countries. Regarding digital healthcare, it is evident that there is a rapid development of this. Not only the data gathering, but the use in diabetes management. This process offers new perspective for the improvement of diabetes care, but however, it is essential that the education that I mentioned, we can call it maybe continuous professional development, is there also as a sort of if not formalized, then very frequent approach in order to enable diabetes nurses to take to accomplish their roles. And in this context, a constant adaptation of healthcare system is something which we need. Paradoxically, a little bit, this continuous development, professional development in the area of digital healthcare might be of enormous benefit nowadays in the COVID era, in which we are facing the need for the digital communication to the patients, and digital communication at all levels, and this might represent an important tool to prevent these chaotic and disastrous consequences of the pandemic. So, of course, you might have suggestions to that, but I do believe that this might be the basis. And thank you very much for being patient to listen for my talk.
Thank you very much, Libosa, for these closing comments, for wrapping it all up for us. I would once again like to thank all speakers for joining us, especially for staying on overtime. I would like to thank the audience. We had more than 150 people joining us in between. And even now, although we're 15 minutes overtime, more than 100 people still listening in. Thank you very much for joining. Thank you very much for joining the IDF Europe Symposium at EASD. Enjoy the conference. This is only day number 1. Have a great time, and see you next year. Bye-bye. Thank you.
Thank you very much. Bye-bye.